So I think the next thing I want to focus on is that when we're talking about, prostate cancer and really in any setting, really, I think that, there are a couple different options for patients, and there's not a one size fits all. And I think this is where, where we all have sort of discussed that we really need to be, talking to, the medical oncologist, the radiation oncologist, and the urologist, and all making decisions together with the patient and really trying to figure out exactly what fits their goals and their lifestyle the best, and make an informed decision with all of the team members as a result of this. Dr. Jatwani, would you mind talking about, the difference between active surveillance and observation, and what is the difference between those two, and how do we approach each patient with those?
Yeah, so I think active surveillance means, sometimes what happens is when you have a low risk prostate cancer, after you have done surgery on them, in some cases where you're not doing surgery, you can keep on monitoring their PSA regularly. Again, active surveillance should be thought of, or observation should be thought of as a treatment arm. The reason being that, we don't want to intervene unnecessarily if we don't think that it is not going to benefit the patient. Any kind of surgery has its own risks, and we don't want our patients to go through a situation where they might end up having lifelong irreversible effects. So yeah, I mean, I think both these situations you can encounter during your treatment phase. Sometimes not doing something is much better than going around and pushing buttons. And we have actually seen that active surveillance and observation helps a lot of the patient who will eventually end up living a normal life without any problems. But Dr. Tawagi and Dr. Kurian, would love to hear your thoughts as well.
Yeah, I agree. I think there's a lot of slow growing prostate cancers. So in the appropriate patient, perhaps more elderly patient, especially if there are other health conditions that may limit their life expectancy, it makes sense to take this approach because the prostate cancer probably won't limit their life expectancy and is unlikely to cause problems if it has some of these lower risk features. So I think it's appropriate for a lot of those patients.
Definitely, without a doubt. And then, we've talked about, there are certain people that we feel that upfront surgery can benefit those folks. And then, it gets a little bit more nuanced in terms of, if you have surgery up front, and what your options are after if the prostate cancer were to come back versus if you have radiation up front, what are the options? And we won't go too much into that, but that's something that is definitely a discussion amongst all of the members of the team. And I don't think there's one correct answer. So I think it's something that you need to discuss, with your medical oncologist, radiation oncologist, and urologist about what fits best for you. And typically, at most cancer centers, they have something called a tumor board, where basically all of the team members will come together and discuss your case and discuss, in your specific situation, what would be the best potential next step or upfront step in your scenario and your prostate cancer based on, like the things we talked about, the Gleason score, whether lymph nodes are involved, and the PSA level, and your other medical conditions. All these things sort of play a role. And then obviously, the patient is really making the final decision about which route they really want to take based on, what they think is best for them as well. And then we'll talk a little bit about hormone treatment. Dr. Tawagi, could you talk a little bit about hormone treatment and how that works? And, we'll talk a little bit about some of the side effects, but how do you sort of counsel patients about hormone treatment exactly?
Yeah, absolutely. And I think I just wanted to add, the decision of surgery versus radiation. Sometimes both options are not an option for the patient, depending on how much what the size of the tumor is and what some of the other features are. And so a lot of times I see patients and they say, oh, well, I talked to my one friend and they had surgery, or my other friend had radiation and I'm undecided. But I think it's really important to listen to your healthcare provider team, because even though it's great to have support from other people that might have gone through prostate cancer treatment, there's a lot of nuances in terms of who can get surgery. The tumor needs to be small enough, and then sometimes radiation is a better option. So in some cases, they're both equal options and they're offered to both patients.
Right.
And so in those cases, maybe it's useful to talk to someone that has gone through that same decision and then to find out, what kind of side effects they're having, how their life is after surgery or after radiation. And so in terms of hormone therapy, a lot of times when you have prostate cancers that are just in the prostate, but that have higher risk features, or if the cancer has spread to further places, we recommend hormone therapy. And the way that I describe it to patients is that testosterone, the male hormone, is the fuel to the cancer. And so in the cases where the cancer is still localized, the radiation is killing all of the cancer cells in that specific area. But if there are any remaining cancer cells that we're not seeing that are not in that area, we're taking that fuel away with that hormone therapy to reduce the chance of the cancer coming back.
Right.
And then in the setting where the cancer has already spread outside of the prostate, we also want to remove that fuel. And so that's why we give these hormone therapies. And usually the backbone of this hormone therapy are injections, although there is one pill option, and they're given generally every 3 to 6 months. I know we're going to get into more details on those and as well as side effects. But basically, you want to take away the fuel for the prostate cancer growth by lowering the male hormone, the testosterone.
Definitely. And then, the last option that, really I think is really more limited to very, very high risk prostate cancers, or that Gleason score being a little bit higher, and other risk factors that may put the patient at higher risk of recurrence of their prostate cancer. Sometimes we will talk about adding different male hormone targeted pills, into the mix as well. And that is also, a discussion, with your medical oncologist as well.